Hello, I'm Dr. Mas Chaponder, Clinical Research Fellow at the University of Liverpool. This is the third lecture on therapeutics for the MRCP Part 2. In this lecture, we'll consider drug interactions and drug side effects. Let's look at question number 1. A 72-year-old man is seen in cardiology clinic as a follow-up after a recent admission with atrial fibrillation and myocardial infarction. Since discharge, he has noticed a rash develop over his face and neck when he is out in the garden. Which one of the following is the most likely causative agent? Again, here you will see an extreme version of the rash that he is talking about. And there are 5 drugs to consider. Please consider wisely. So that was a photosensitive rash, and the drugs that are typically associated with that are amiodarone and, to a lesser extent, ACE inhibitors. So the choice here is really between C and E, and the most obvious one is amiodarone. The extreme case of photosensitive rash would be a slate gray skin pigmentation, which was what was in that photo, again typical of amiodarone. Simvastatin is more likely to cause hypersensitivity and rhabdomyolysis. ACE inhibitors, as I said, can cause to a lesser degree the photosensitivity rash. Warfarin causes alopecia and thinning of the skin. Metoprolol would really be causing nightmares and not really these associated symptoms. Let's now consider question number 2. A 42-year-old man is referred to a dermatology clinic with a rash which has developed over his arms over the past 2 weeks. His past history includes hypertension, for which he takes lisinopril and bendrofluozide. He is also known to suffer from manic depression and has been taking promazine for 6 years. He was reviewed by his psychiatrist 6 months ago, who started him on lithium. He has recently been complaining of some indigestion, and his GP has started him on lansoprazole 2 months ago. On examination, he has a scaly rash localized over the extensor aspects of his elbows. Therefore, which one of the following agents that he is taking is most likely to have precipitated this rash? Please consider these 5 options and choose carefully. I'll give you a moment to consider them. This gentleman has a case of psoriasis. The description of that scaly rash on the extensor surfaces would be in keeping with psoriasis. Drugs that would worsen that and induce psoriasis would include lithium, and I think that's the only drug in his medication and his medical history that has recently been changed which would fit with that. Other drugs that can induce and worsen psoriasis include beta blockers, non-steroidals, and even anti-malaria drugs. Let's now look at question number 3. A 52-year-old man with a history of COPD presents with jaundice. He has a history of hypertension, for which he receives ramipril and amlodipine, and hypocholesterolemia, which is treated with a statin. He takes theophylline tablets for his COPD. He consulted his GP 2 weeks earlier and was prescribed an antibiotic for 2 weeks for a lower respiratory tract infection. On examination, he is jaundiced and he has signs of scratch marks over his upper body. He tells you that he has been passing dark urine. We can see here a photo of his eyes showing the jaundice. When we look at his bloods, we can see that his white cell count is normal, his renal function is normal, but his bilirubin is markedly raised. He also has a raised ALP and an ALT. The most marked finding here is the raised ALP. So, which one of the following antibiotics is most likely to have been responsible for the picture that we have seen here? So, this gentleman has an obstructive jaundice or cholestatic jaundice with the raised ALP and clearly raised bilirubin. And we're told that he had a recent antibiotics about 2 weeks ago. The only one of those antibiotics that can do this is coamoxiclav. So it's not the penicillin moiety in the coamoxiclav that does this, but it's thought to be the clavulinic acid, which would cause an obstructive cholestasis. Ciprofloxacin, cefalexin, penicillin, and erythromycin are all antibiotics which he could have been given for an upper respiratory tract infection in someone with COPD. However, coamoxiclav is the one that would have caused the obstructive jaundice. It's interesting to note that the coamoxiclav may be withdrawn and the jaundice might develop after it's been withdrawn or after the treatment has been completed and might continue for a few days and even longer. And it's thought to be an immune-related reaction, not just the drug causing the obstructive jaundice. And now on to question number 4. A 17-year-old girl is studying for A-levels, now presents with clumsiness and falls. Her mother reports that she frequently drops china and cutlery at home. Her school teacher has noticed odd behavior over the past 2 months and her work has deteriorated. Her brothers and sisters have no health problems. Her father is epileptic. On examination, she has horizontal nystagmus, dysdiadochokinesis, and a broad-based gait. Which one of the following represents the most likely diagnosis? Is it phenytoin toxicity, intermittent cerebellar syndrome, Wilson's disease or meningioma, or even multiple sclerosis? Please consider wisely. This is a difficult question. She has phenytoin toxicity, and there are few clues in the history that we are being told. The first, we know that this is a recent development, and we're told that her father is epileptic. So she is having access to his medication and is probably overdosing or dosing herself on his medication, probably as a response to her A-levels, which are stressing her out. The thing that tells us that this is really phenytoin is that she has horizontal nystagmus. So a few clues there, and then the little clinch at the end is the horizontal nystagmus. Just to review phenytoin toxicity and the side effects that phenytoin can cause. So it will have this horizontal nystagmus, which is very pathognomonic, diplopia, slurred speech, ataxia. All these you will notice are cerebellar symptoms and cerebellar signs. She can have confusion, of which she has been presenting with, and hyperglycemia can occur in rare occurrences. Here is an extreme example of someone who's been on long-term phenytoin treatment, and you will notice gum hyperplasia. Again, this would happen with phenytoin. Let's now consider question 5. A 75-year-old lady is admitted with confusion and general deterioration. She was found in her flat in a state of self-neglect. In hospital, she's diagnosed with a left lower lobe pneumonia and commenced on antibiotics. Her medical background includes angina, atrial fibrillation, osteoarthritis, asthma, and diabetes. Her medication is GTN spray, digoxin, warfarin, codeine phosphate, salbutamol, and Becotide inhaler, as well as metformin. She is commenced on amoxicillin in hospital. Whilst an inpatient, she improves, and the house physician on the ward notices a lesion on her scalp. It is a small, irregular erythematous papule surrounded by pale, brittle hair. A dermatologist reviews the lesion and takes some hair samples for further examination. After microscopic examination, he returns to the ward and prescribes a shampoo for the patient and an oral antifungal agent that works by inhibiting the mitotic spindle of the fungus. What will be the most likely to do to the patient's blood results? Please consider these options. This is a difficult question because it assumes several things. It assumes that you will know which antifungal inhibits the mitotic spindle of the fungus. You could take a guess, actually, if you didn't know the mechanism of action. If you just knew the fact that she's on warfarin and they're saying what will be the most likely effect on the patient's blood results, and then they're talking about the normal and the abnormal warfarin levels. So a decrease in the international normalized ratio would be caused by one drug. And the drug that is being used here, the antifungal, is griseofulvin. And I think I will talk about two important antifungals and how they have opposite effects on the international normalized ratio. So griseofulvin is an enzyme inducer. And you remember from lecture 2, we talked about enzyme inducers in the CRAP GPs, which induce the cytochrome P450 enzymes, which lead to the metabolism of drugs such as warfarin. So in this case, the griseofulvin is metabolizing, leading to a metabolism of warfarin, and therefore the INR will decrease. She therefore requires much bigger doses of warfarin. It's important to differentiate this from another antifungal, which could be fluconazole. So fluconazole is a potent inhibitor of the cytochrome P450 enzyme. And if we go to the next slide, what you will see here is the process of inhibition. So in short, inhibitors inhibit the breakdown of drugs. So fluconazole inhibits the breakdown of warfarin. What that effectively does, it increases the INR. So warfarin hangs around in the body longer and the INR will go up and up and up. So if it was fluconazole that she had taken, her INR would have gone up. Because it's griseofulvin, it has gone down. And the only way of knowing that it's griseofulvin is that it is the antifungal that inhibits the mitotic spindle of the fungus. So a very hard question indeed. Let's consider question number 6. A patient on the ward with HIV starts complaining of severe left-sided lumbar pain that radiates down the left side to the groin. An abdominal X-ray reveals an opacification at the left pelvic ureteric junction. His LFTs show a raised bilirubin, a raised ALP, but a normal alanine aminotransferase and a normal albumin. Which one of the following medications is likely to cause his symptoms? And here we have 5 HIV drugs that are used in the treatment for HIV. Which one of these is likely to lead to these symptoms that he's presenting with? Unfortunately, this is one of those questions, either you know it or you don't. You can't work it out. So indinavir and another HIV drug called atazanavir are the only 2 HIV drugs that are associated with renal stones. Indinavir, being a protease inhibitor like atazanavir, also affect the liver, and so it is not unusual to find abnormal liver function tests. Ritonavir is only used to boost protease inhibitors. Zidovudine causes anemia, stavudine causes lipodystrophy, and efavirenz causes weird dreams and psychological effects. Let's now look at question number 7. A 29-year-old woman presents to her GP complaining of tiredness, lethargy, headaches, and tremor. She received a renal transplant 1 year earlier and takes a cyclosporin-based immunosuppression regimen. 1 week prior to her visit to the GP, she has been started on a prolonged course of fluconazole by a locum doctor in an attempt to clear up a long-standing fungal infection. Her hemoglobin is low, her white cell count is low, and her platelets are all low. In addition, she has a mildly raised creatinine at 230. You suspect a probable drug interaction. Which one of the following is the most likely cause of her problems? Please look at these 5 options and consider wisely. Given the last question, I think this question is easy, and it's put there to illustrate the fact that drug interactions can be predictable, especially in the exams. You're looking at cytochrome P450 interactions here, enzyme induction, enzyme inhibition. And what we have here is fluconazole, which is a very potent enzyme inhibitor, inhibiting cytochrome P450 and therefore inhibiting the clearance of cyclosporin, the mechanism of which I explained in the previous question. So what we're having here are examples of cyclosporin toxicity, and that will present with headache, with tremors, and the pancytopenia that we have seen with the low hemoglobin, low white cell count, and low platelets. What we'd have to do is lower the dose of cyclosporin or stop the inhibition of the drug using fluconazole. To reverse inhibition is quite quick, and so over a period of 3-4 days, fluconazole will have washed out. Let's consider question number 8. A 62-year-old man returns to the emergency department with confusion some 2 weeks after discharge post-anterior myocardial infarction. He made a relatively good recovery and was started on a range of medication. His wife tells you that he has become increasingly vague over the past 3 to 4 days. On examination, his blood pressure is 125/75, his pulse is 78 and regular. He is euvolemic. His hemoglobin is fine, white cells are not elevated, his sodium is low at 127, potassium 4.9 and a creatinine of 110. So, which one of the following agents is most likely to be responsible for this confusion and vague behavior? Please consider these drugs, which are all potential drugs that he would have been started on, all at the same time, and you are the physician who has to consider which drug must be stopped. The only abnormality you could detect in his bloods was the low sodium, so he has hyponatremia. The drugs here all can drop your salts in various ways. So furosemide can lead to hypokalemia, spironolactone can lead to hyperkalemia, ramipril can also lead to hyperkalemia. But citalopram is the only one that drops your sodium. So this is a syndrome of inappropriate ADH secretion. Other drugs that would do a similar manifestation would include carbamazepine and antidepressants such as amitriptyline, so tricyclics. All these would cause a syndrome of inappropriate ADH secretion. I hope you enjoyed the 3 lectures on therapeutics, covering a wide range of areas from overdose to tricky questions and management of difficult questions, to side effects and drug reactions, which can be predictable if you understand the cytochrome P450 drug reactions. I wish you the best of luck in the coming exams.